Okay, good afternoon, everybody. Yesterday, I happened to come quite early to Rome, so I had a chance to go to Colosseum. So, trying to show off. In fact, the analogy is that it is a colossal task for me to try and talk about this topic. Mainly so because I've chosen this only about 3 weeks ago, when I registered for the conference, and I noticed that abstracts were still being accepted. So I thought, okay, let me try, and I put forward this topic, and to my surprise, it was accepted for oral presentation. Okay, I thought, fine, it's a nice challenge to have, so let's go ahead with it. And I still managed to finish my presentation this morning. so let's see how it comes. I want to try and be quick through the presentation because there are lots of slides and too wordy as well. So I hope you won't sleep off. There are three aims here. One, I want to kind of emphasize that we as mental health practitioners have a role to play in enhancing the standing of psychiatry as a medical field, medical discipline, because medical disciplines are all about practicing evidence-based medicine, right? But I also want to kind of take a step forward to make my observation that we often tend to focus a lot on objective kind of research in psychiatry, and to me it's not truly representative of psychiatry, because as it is, mind, in my opinion, is in subjective space, and therefore a lot of research around it should be considered as subjective too. So therefore my consideration is that yes, it is a science, but the foundation should be predominantly about subjective research. I also would go another step forward in trying to kind of bring in the idea of spirituality into mainstream psychiatry. This is an area which I have been looking at, especially in the last 1 year, and not that I haven't had inclination towards it. It's not that I didn't have an understanding, but somehow it's starting to make sense when I see my patients and whether it actually applies in the aspect of helping them recover. And I'm going to only talk about non-psychotic psychiatric conditions here. So I'm not going to entertain an idea in my mind that psychosis also has or spirituality has a role to help in psychosis. I don't want to go that far yet. I believe that we have come a long way in psychiatry, and we have brought in the kind of acceptance of mental well-being in the society. It's a core aspect of health for every individual. So we are now giving space for everybody to talk about their problems. A lot of celebrities across the world have come up openly talking about their own problems and actually become role models in that sense. We have also kind of helped destigmatize a lot of things said about psychiatry or the way people feel about it. And we also have come a long way from what was more like a closed-in asylum kind of care to now more of a open within the community, at-home kind of psychiatric care. However, I still think there are several challenges, which are, some of them are at least conceptual in nature, and that's where I'm going to talk about today. The main areas where we clash is science, philosophy, and human rights. I won't touch about human rights here. Okay, we all know that evidence-based medicine is really about making those kind of critical kind of decisions based on facts as much as possible, rigorously studied, and then we have come to findings which can be put into practice. And these should be applicable at an individual level. We need to make sure that they are at the end applicable on the concept of patient-centered care. Why do we actually want evidence-based practice? There are several advantages. One, we have numbers to back our decision. Whatever we want to convey to the patient, we actually can talk about this many percentage of patients have responded to a particular medicine and so on and so forth. We have guidelines to fall back on. We look good, professional, and we look confident. And naturally, it helps in more scientific kind of studies over the period of time. Reassuring patients and family, and if we are challenged in court of law, and so on. Now, most common criticism, if I can put it into a few categories, is what's the basis for labeling something as a disease? So they're questioning the etiology. How watertight are our diagnostic compartments where we have overlapping features, let's say, for instance, depression, anxiety, depression, dementia, and so on and so forth, or borderline personality and so on. How reliable is our information to come to a diagnosis? Information bias, whatever information is put to us, is the output is going to be this related, dependent on it. And do antidepressants work when we actually know that the primary reason is actually social in nature, nothing to do with the biological kind of process of depression? So is there a kind of diagnostic confusion, medicalization of social problems? And by the way, where is mind located? So this morning I was actually hearing to the first speaker, Suzanne, I think her name is, and I don't think she's here right now. And she was also talking about how we end up having more labels nowadays. I think it's a debatable aspect. I don't think it's quite a bad thing. But when it is overused, then of course there is a problem. Reliability of psychiatric diagnosis naturally depends on patient factors, clinicians factors in the sense where they come from in terms of what's their training background, what are their own biases that they come with. And of course, methodology in terms of the kind of assessment processes that we have. If I'm a little provocative in between, that's okay. I guess we can have a debate later on. Where does evidence actually apply in psychiatry? Now, I look at it this way. When it comes to etiology, do germs cause mental illness? They don't. Can we kind of get a tissue section and look under the microscope and find depression? I don't think so. Can our scans actually tell us, apart from maybe dementias, not much else? Biochemistry, none of the blood tests. So I don't think evidence really applies in etiology. Symptoms are present, but where are the signs? If I have abdominal pain and I look for a rebound tenderness, let us say, there is a sign there, but I don't think I can find signs in mental illness. Treatment, this is definitely a place where evidence applies. So let's be objective about it. And here we have no problems. So therefore, is psychiatry on shaky grounds? Has it been correctly identified or defined, or is it just the public perception which tends to overshadow? I mean, it's a very simplistic definition, and I don't think it's any different to how we all understand psychiatry. Here, it's just a field of medical sciences. We deal with assessing and diagnosing mental illnesses and want to treat it. And it's a field where we want to practice holistic medicine, and we want to have a multidisciplinary kind of an approach. But I don't think it entirely explains what psychiatry is about. There are gaps. This can't be able, this is not able to explain what psychiatry is at the end. Okay, so perception of psychiatry. We just need to look around in terms of the studies or sometimes even newspaper articles. For instance, when DSM-5 came about, we have seen the kind of antagonism in some sections about how it was again another opportunity or a failed opportunity, in fact. This is a study from 2014 which talks about the negative perception among even the medical students and of course the general public. and it was also explaining how few trainees end up in psychiatry. And this is the second one is a little more alarming, and this is from 2015, and it says 90% of the medical teaching faculty that they have surveyed felt psychiatrists were not good role models for medical students. Now, I don't think it's felt that way across the world, but anyway, that's part of the study. But interestingly, they say that they have sampled various countries, including Asia and Europe. But that's the perception. We can't debate individual's perception. That's the problem. Then this is a little older systematic review, I think, or meta-analysis, which talks about at least a significant proportion of the studies saying that the mental health professionals did not have any better attitude towards psychiatry compared to the public. In general, I think the tension exists in terms of how do we define psychiatry per se, and it has its implications on teaching, learning, research. So what does a psychiatrist feel at the end of the day? Fighting the criticism, I feel I'm not understood. I feel it's an unfair portrayal. Okay. I feel I'm not valued enough because not all my results can be quantified, and especially the duration of the illness, the remission rate, the revolving door, and so on and so forth. And perhaps the negative portrayal can humiliate me as well. But should I really be cowed down by it and feel defeated? I don't think so. I would then accept the criticism, and I want to take it a step forward, and I want to enhance my image, my as in psychiatric image, among the medical family. I want to enhance my image among, in the general public. I want to value myself, and I want to accept the limitations, and I want to do best within the scope of the limitations, which basically means that use every attribute within it to the maximum extent possible. Now, interestingly, I also have seen this and experienced it both in medical general hospital settings and elsewhere too. There is often some cherry picking that tends to happen, which puts psychiatry at a disadvantage. For example, if let's, for argument's sake, the day when mind is found, when mind has an anatomical location, it will go into the territory of neurology. Right? So it's as simple as that. Why is that? It's because the medical specialties have an advantage of image, number one. And then they have a foundation very firmly on objectivity, objective medicine. So therefore, you can't really you are going to be, whenever there is an overlap, I'm talking about overlaps. Whenever there is an overlap, they have a better advantage than psychiatry. So all this, I'm trying to make a case here why we need to really sit back and look at the strength of psychiatry to be the subjective science. Right. So again, I feel that if it is the objectivity that we pursue in terms of doing studies after studies, looking for that elusive anatomical or physiological substrate, I think we'll possibly be doing injustice to ourselves. I think we need to focus as much on subjective research as well. If mind is in a subjective space, then all research should be considered to be subjective too. So if subjectivity is the core feature, is evidence-based practice compatible with psychiatry? I feel it is. there are ways to kind of, I'm not a researcher, by the way. I can talk, but I think I don't have time for it. That's the problem. So we should find ways to study subjective experiences by replicating them in larger numbers. One person giving an experience, wow, that's beautiful. Sorry, it's only one. I need 100, I need 1,000. Then at least I have a larger pool. So I'm making it as much of a valuable kind of knowledge. And quantifying subjective experiences. I think there should be a time when love, joy, whatever, I'm sure we were talking about psychometrics here, but I'm sure if they are rated, if we are able to quantify those things, perhaps it could be a game changer. Maybe people are already doing it, I'm not aware of it. But yet, it's not going to be the same as objective science at the end of the day, but that's okay. So for us, I think the core strength lies in thinking well. We need to think well at multiple levels. At conceptual level, as we were talking about earlier, in picking up the subjective-based research areas and focusing more on how do we do better with that. And I spoke about quantifying the subjective experiences. Using all available information in clinical assessments, we need to have, I find it difficult to explain here, but I do it in my practice, where I also tell my medical students how every aspect of my observation has place in final conclusions in terms of assessment and management. Because that's the only thing I can do. I can't rely on anything else. Whether it's I may ask a nurse's observation, I may ask my team's observations, the patient, the family, and my own observations of the patient and so on and so forth, whatever it could be. I want to use every part of it to come to a conclusion. Now, I also will be talking about this particular aspect later in the slides. Psychiatry has done very well for itself by being uniform globally. We have diagnostic criteria and the way we practice and so on and so forth. But at a local level, I still think that the world is big enough and diverse enough that we need to encourage local nuances to be understood so that the patient at the end gets the best out of it. How do we do it? Maybe I can put forward a couple of slides to explore that. And there, interestingly enough, this is again my observation coming from an Asian background. Compared to any other medical science, psychiatry has a lot of other parallel informal support systems or healing processes. In India, for instance, there's homeotherapy, there is Ayurveda, there is Unani, and then you have crystal healing, you have Reiki, you have pranic healing. You can go anywhere if you want. But somehow these are not captured within formal psychiatric setting. So why is that happening? Is it the reluctance to accept a worldview? Whichever it is, we need to really look at it. Okay, I don't know how we are doing the time. Are we okay?
5 minutes.
Is that all? It seemed like I was only halfway through. Okay, then in that case, I'll skip through.
7 minutes.
Okay, we touched on this. I think we need to really look at how we identify the need to bring psychiatry to a local level. The reason I also mentioned is that there are still, although we are turning quite homogeneous, we're speaking the same language, we're speaking the same dress nowadays. At home, I may dress a bit differently. We are all dealing with same social media nowadays and so on and so forth. We're homogeneous now. But still, I think at a local level, we are different, especially in countries which are so way different. So I think it's important that at a local level, training should include those aspects of sensitizing psychiatrists to the nuances of the local population. Anybody knows which bank this is? It's HSBC. They proclaim themselves as world's local bank. Okay, now I'll come to this topic which I hope I can make a case. Now, this is now so different to what we are tuned to in terms of thinking. See, spirituality touches a raw nerve for a lot of people, understandably, because it's somehow clubbed with religion. I don't think we are talking about religion here. So the basic premise of spirituality is acceptance of a universal consciousness or a divine energy. Now I'm using the word divine. And that we are all qualitatively the same, you, me, everybody, as the divine energy, but quantitatively part of the whole. So that's spirituality. It could be defined a little differently in different contexts. Some may water it down to no more than individuals' own search. Actually, that's not spirituality. It is individuals' journey to find meaning in life, fair enough, with a goal of being in connect with divinity. And there are several attributes which are in association with those, like truth, unconditional love, etc. So why does spirituality matter? And I found this particular abstract which I think helped me in summarizing. So there are various aspects like creativity, perseverance, honesty, kindness, compassion, hope and joy, and so on and so forth. These are important in terms of healing and recovery in psychiatric setting for patients. And perhaps an understanding of this among the clinicians could go a long way in helping them. And this is exactly what is happening in the parallel systems. We in mainstream don't do this, we don't touch it. So the patients are dealt with in parallel systems. A lot of them. I don't know whether it happens in the Western section society, but it happens in Singapore, it happens in India a lot, happens in lots of Asian countries. Now I believe that I coined this word despiritualization. Whether it exists or not, I don't know. I believe it's unique to modern times, and it comes from this understanding we have that science requires objective evidence. So therefore, we already touched on it. Is everything in psychiatry objective based? The concepts of defense mechanisms and psychological theories and so on, which have been in existence, where is the objectivity for those? They are all subjective, proposed by the proponents of them. Psychoanalytic theory, Oedipus complex, id, ego, superego. Can anybody say with confidence that there is objective evidence for these things? These are proposed. These are proposed by an individual or 2 and 3 and 4. Not replicable, but accepted. So if these are accepted, what's the difficulty in accepting spiritual concepts, which have been actually detailed in several geographic settings, several times, time periods, well documented and consistent as well. A lot of them have been consistent. And I'm citing few I have read myself, and over a period of time I hope I will read more from across the world. Surely there are consistent descriptions in Bhagavatam, Bhagavad Gita, Tibetan Buddhist texts. I haven't read that yet, and Plato's view I have read of it a little bit, but not much more. So there is consistency if you look at it, but it's not talked about, it's not included in mainstream psychiatry. In fact, interestingly enough, especially in India, perhaps in lots of Asian countries as well, spirituality was part of it was core component of education, health, and living day-to-day life. But it's now divorced. You don't talk about it in educational settings anymore. It's a big no-no in health. So there is a problem there. Ayurveda till date, for instance, includes spirituality as a key component in understanding the person as a whole, holistically. A good example of de-spiritualization is yoga, the way it is practiced, especially in West. It's heavy on aesthetics, physical fitness, but definitely less about spirituality. Okay. So what we therefore have is, almost done, I hope. What we therefore have is, we have a psychiatric space which is despiritualized, an education space which is despiritualized, and the individual in his own private space is heavily into religion, heavily into spirituality, or even atheism for that matter. So we are cocooned. We're not talking about it openly. We're not embracing openly enough. We need to at least have an exchange where there is opportunity for us to learn from patients and patients to learn from us, maybe. So I feel that we need to really start looking or thinking about this, even at least at a local level, if not at a global level. Wherever, whichever geographical setting it is relevant, at least it should start there without any hesitation. I'll give you a taster. Basically, a person who doesn't consider spirituality as a concept may think he is invincible. Whereas a person who considers spirituality as a concept knows that physical body is just a vehicle for his growth. Immortality of self is something which somebody having spiritual kind of bent of mind has, because of the concept of reincarnation and perhaps whatever may be the concepts. I and mine, for instance, all things about me may need to lead to kind of negative emotions, whereas the universal consciousness, everybody is me, may bring in love, trust, and sharing. And I like this particular concept called vidya versus avidya. Now, vidya is knowledge, avidya is ignorance. Interestingly enough, vidya or knowledge is about ultimately knowing what is my role in this universe. As long as I have understood it, that is knowledge. Everything else is not. So that's the stark difference that we are in right now. There was a time when this is how possibly the world viewed knowledge, and we are seeing knowledge very differently now. So it doesn't mean that we just include it for the sake of it. We need to make sure that if spirituality is included, we need to continue to assess its therapeutic benefit, the feasibility, acceptance, therapist attitudes, and only then we need to kind of practice it in mainstream. I do think that there are encouraging indications. This is something I picked up from an article, but there are other sources as well talking the same things. Nowadays, I'm sure those who have heard of Dr. Brian Weiss and other psychiatrists who have come up with concepts of regression therapy and so on also talk about the same things, where spirituality seems to be heading in the right direction in terms of research. And this is again from Vatican Museum. I went yesterday, the guy with the flute. And I shared this picture with my wife and she said, wow, that looks like Krishna. So I put Krishna over there as well. The symbolism here is, this is beautiful, but that's beautiful and divine. All right, thank you very much.
Any questions?
Yeah.
we experienced the psychiatrist with the role they only prescribe the medication.
Right.
And the research at the psychiatric medicine is prescribed medication, works good with the behavioral therapy. But in my research, I read the Carl Jaspers, Bleuer, Kurt Schneider, which this is the objective of the psychiatrist. The common psychopathological. And it's a 100-year-old objective for the psychiatrist, but there is no research. No,
Yeah.
The younger psychiatrist, no, there's only this biological, social, psycho and social approach that is okay, but it's only biological nowadays. As for the psychiatrist, it's only biological. But the drug management, medication, and the other professions, social workers, psychologists, nursing, do the social and psychologist work. It's in research and in practice. It's very hard, I think, for the psychiatrist.
I think the only way forward is to kind of be open to learning from everywhere, but at the same time maintain that level of the scientific approach to how we understand and include. But for that to happen, we need to dedicate ourselves sincerely into studying any mind sciences. Okay, thank you. All right.